Next, we have a very, very cool speaker. This is going to be something different, okay? This is, we have one of my good friends. This is an ethicist. And we actually lived real close together in Arizona when I went to medical school. He was, he got a JD, a Juris Doctorate from BYU, and decided that that wasn't just enough school. So he went back and got a master's and a doctorate in philosophy from Arizona State University, and now he's a professor over at Florida Tech. We've actually written a paper together on the ethics of the doctoral honorific, which was kind of a fun paper to write. But he's going to talk to us today about the ethics of prescribing lifestyle modification versus prescribing like the standard of treatment, the current standard of treatment. So let's give it up for Dr. Kenneth Pike.
Well, good afternoon, and thank you for being here. It's humbling to address so many people who know so much more than I do about so many practical things. As Scott suggested, I'm not a physician or nurse. I'm not a therapist or other healthcare provider. Unlike most of your presenters at this conference, I have no medical knowledge to offer you today. I am a moral and political philosopher. I research ethical and legal theory. And if you wonder about the value of such pursuits, well, sometimes I wonder that myself. As I occasionally pose the problem to my students, what is the difference between a philosophy professor and a large pizza? Well, a large pizza, you see, can feed a family of 4. And this is what artificial intelligence thinks philosophy professors and large pizzas look like. Nevertheless, over the course of your career, you will almost certainly work with someone like me, if indeed you have not already. Perhaps you will need research approval from an institutional review board. Maybe you will contribute to the regulation of your profession as part of an ethics advisory committee. You might be involved in a lawsuit as plaintiff, defendant, or expert witness. You could be called upon to advise patients or their families on matters of grave ethical import. And even if you somehow avoid all such interactions, the moral dimensions of medicine will still be there lurking in the background of everything you do, an inescapable aspect of your professional practice. In the time I've been allotted today, I have 2 primary goals, one general and one specific. The general goal is to enliven your own sense of the moral dimensions of healthcare. If all I accomplish today is to get you to spend half an hour reflecting on your ethical obligations, I will regard the time well spent. In medicine, as often in life more generally, the urgent and deeply practical demands of others can sometimes crowd out more abstract and personal concerns. This is often so even when those concerns are of great importance to the enterprise of addressing practical demands in a sustainable, morally defensible way. In hopes of inspiring such general ethical reflection, I will offer a defense of a specific ethical claim. The claim is that the practice of lifestyle medicine is morally permissible. This may sound like a modest claim, or even a trivial claim. But I think it is an important claim to articulate for at least 2 reasons. The first is that, in the practice of medicine, it is unwise to assume the permissibility of anything. If the practice of lifestyle medicine is indeed morally permissible, we should be able to articulate that in a coherent way. Conversely, if we're unable to articulate the moral permissibility of lifestyle medicine in a coherent way, that should give us pause. The second is that some commonplace approaches to lifestyle medicine are already being criticized as morally impermissible. I think these criticisms are misplaced and generally mistaken, but an examination of the moral permissibility of lifestyle medicine should help us to get clear on why they are mistaken. To proceed with that examination, I need to begin by clarifying a few key terms. Most importantly, when I say lifestyle medicine, I am specifically referring to the exercise of competencies endorsed by the American College of Lifestyle Medicine and the American College of Preventative Medicine in Leonov and Johnson's Physician Competencies for Prescribing Lifestyle Medicine. Built into these competencies are a number of substantive assertions, several of which are directly relevant to the ethical argument I will develop here today. 1. Healthy behavior is foundational to medical care, disease prevention, and health promotion. 2. Tobacco use, alcohol consumption, diet, physical activity, body mass index, stress level, sleep, and emotional well-being are all pertinent to lifestyle-related health status. And 3rd, healthcare practitioners should aim to affect and sustain behavioral change in their patients' lives. Another terminological clarification is that when I say permissible or impermissible, I am speaking in a contractualist sense. Contractualism is an account of moral permissibility developed by philosopher T.M. Scanlon, especially in his book, What We Owe to Each Other. You may have heard of contractualism if you have ever taken a course in ethics or watched NBC's afterlife comedy, The Good Place. But you are more likely to be familiar with competing accounts like deontology or utilitarianism. On the contractualist view, what makes an act morally impermissible is not whether it fails to effectuate the greatest happiness for the greatest number of people, or whether it violates some categorical imperative, but whether it violates a principle for the general regulation of behavior that no one could reasonably reject as the basis for an informed, unforced general agreement. Typically, reasonable rejection is expressed in terms of personal cost, a harm to one's own interests that is weightier than the harm to anyone else's interests that would be done by an alternative principle. So the identification of moral principles is typically made by an informal comparison of losses. To illustrate by a perhaps familiar example, consider the nature of medical battery, not the kind that go in your computer. Medical battery is, in legal terms, something courts of equity may grant damages for. In other words, medical battery is so impermissible that patients can bring a lawsuit to recover monetary damages when it occurs. Medical battery is not malpractice. In a malpractice case, and this differs a bit from state to state. I'm not an attorney in Utah, so none of what I say should be construed as legal advice today. But in a medical malpractice case, a plaintiff must typically show that they were harmed by negligence or some other breach of a clinician's duty. By contrast, there is no harm requirement for medical battery. The tort of medical battery occurs when a healthcare provider engages in any unauthorized contact with a patient. That's it. No harm is required. The usual case of medical battery these days is one where informed consent was not obtained in advance of a medical procedure, for example, when a surgeon performs an operation on the wrong patient. But if unauthorized contact causes no actual harm, what makes medical battery morally impermissible? The contractualist approach invites us to consider two competing principles for action. On one side, you've got a principle permitting unauthorized medical treatment so long as no harm is done. And on the other side, a principle forbidding unauthorized medical treatment even if no harm is done. According to Scanlon, whether a principle could reasonably be rejected depends on a comparison of the reasons that can be offered against it with those that can be offered in its favor against alternative principles from the point of view of people who occupy various positions in a situation of the kind to which the principle applies. We never know exactly which individuals will occupy these positions in all the various situations of this kind, so questions of right and wrong must be the ones we can answer in the abstract without such knowledge. The reasons we consider in assessing a principle are therefore not precisely the reasons that a particular actual individual has, but what are called generic reasons, reasons that people in question would have in virtue of being in the positions under discussion. So, what generic reasons are there to reject a principle forbidding unauthorized but harmless medical treatment? In other words, what defense of unauthorized, beneficent treatment can we imagine? Paternalism may qualify. Sometimes patients are bad at knowing what is good for them, so it may be to their genuine benefit to override their own choices. But this must be weighed against the reasons we can offer to reject a principle permitting unauthorized beneficent treatment. Patients have extremely weighty reason to reject such a principle because it violates their autonomy. People who are in the position of patient have already had authorship of their own lives, their autonomy, diminished by the realities of their medical circumstances. So the interest those patients have in preserving what remains of their autonomy is generally quite weighty. On balance, patient autonomy is weightier than beneficence. But the generic analysis I've offered so far has an obvious exception. In emergency situations, for example, where consent cannot reasonably be obtained in advance of a life-saving procedure, medical practitioners can't be faulted for acting on their best professional judgment rather than on the explicit permission of their patients. Such hypothetical situations are often clearest in retrospect. So imagine you have received a medical procedure without your consent. You ask your care provider, "Why did you give me that treatment?" without first obtaining my informed consent. If they say, "I did what was best for you, I don't need your permission to do what's best for you," presumably you will find this explanation lacking. If the roles were reversed, then, you should not expect others to accept such an explanation from you. But instead, suppose you ask your care provider why, and they honestly say, "The immediate likelihood of irreversible harm meant a decision had to be made quickly before there was any possibility of consulting with you, so I did the best with what I had." Presumably you and any reasonable patient and any reasonable jury would indeed accept that explanation as justificatory. Lifestyle medicine is rarely, if ever, concerned with matters of dire emergency. But this does not free lifestyle medicine from the demands of moral permissibility. It only means that the ethics of lifestyle medicine are less obvious at a glance. Again, we can weigh two competing principles for action. On one side, we have a principle forbidding the practice of lifestyle medicine, and on the other, a principle permitting the practice of lifestyle medicine. Who suffers losses, and what sorts of losses do they suffer under each principle? One reason why the question may seem modest or even trivial is that the losses imposed by forbidding lifestyle medicine are pretty obvious. Patients have a weighty autonomy interest in informed consent, which means that they have an important interest in receiving accurate, helpful information regarding their medical circumstances. Their interest in receiving evidence-based information on nutrition, drug use, body mass, physical activity, and so forth is therefore strong reason to reject a principle forbidding the practice of lifestyle medicine. Healthcare providers, too, have a weighty professional interest in being free to communicate their expertise. The Latin root of the word doctor is docere, meaning to teach or instruct. A principle forbidding the practice of lifestyle medicine would violate the interest that healthcare providers have in practicing their vocation. So there are clearly many strong generic reasons to reject a principle forbidding the practice of lifestyle medicine. Unfortunately, this is where people often stop thinking about the question. Once they think they have good reasons to do something, they think the case has been made. But counting benefits without counting costs, or vice versa, is obviously a mistake once you realize that's what's happening. So now we have to check the other side of the scale. Whose interests are likely to be harmed by principles permitting the practice of lifestyle medicine? I confess that when I first started thinking about this question, I drew a blank. Diet and exercise have been central aspects of medical practice since ancient times. The famous Hippocratic Oath reads, in part, "I will use those dietary regimens which will benefit my patients according to my greatest ability and judgment." It was not difficult to find critics and detractors of lifestyle medicine, of course, but most such criticism took the form of argument that practitioners of lifestyle medicine could be better at meeting their espoused competencies. For example, One widely circulated piece in the British Journal of General Practice claimed that, quote, a key issue with the growth and prominence of lifestyle medicine, as broadly defined, is its use as a Trojan horse to carry in non- or poorly evidenced practices under the auspices of evidence-based. Under this ecosystem, uncritical adoption of lifestyle medicine may result in inclusion of non-evidence-based integrative medicine, practices thus providing a Trojan horse within which pseudoscience can flourish. Close quote. But the costs identified in this kind of criticism are not imposed by a principle permitting lifestyle medicine. These are costs imposed by a principle permitting pseudoscientific treatment. The claim that evidence-based lifestyle medicine practice would benefit from more evidence is presumably true, and conferences like this one seem like a great place for sharing the evidence as it becomes available. But an argument that practitioners of lifestyle medicine should be even better at what they do is more like a backhanded compliment than a weighty moral objection. On the other side of that spurious coin, I think, are people who claim that pharmaceutical companies specifically, and perhaps healthcare providers in general, are likely to be harmed by a principle permitting the practice of lifestyle medicine because healthy lifestyles would reduce demand for medical services. The idea that any medical professionals are enriching themselves by favoring and fomenting chronic illness strikes me as absurd and maybe even insulting as a caricature. But even if it were true, such charlatans would have no right to their ill-gotten gains, and so their hypothetical objection to the practice of lifestyle medicine would carry no weight against a principle permitting the practice of lifestyle medicine. That said, I was able to identify one potentially meaningful objection to the practice of lifestyle medicine. Some patients do not want their diagnosis or treatment to account for or even reference their lifestyle. For example, one cardiology fellow who moonlights as a cartoonist recently penned an op-ed in the Washington Post describing some of her experiences with obese patients. Charlene Obuobi recommended that patients should, quote, feel empowered to skip the scale, close quote, should ask their physicians about GLP-1 agonists rather than thinking about BMI in terms of personal behavior, and should not be made to feel that their weight is a factor in the care that they receive. Obuobi's apparent aim is laudable. She wants patients to feel autonomous, humanized, and understood, the better to encourage them to work with care providers toward greater personal well-being. So here I think there may be a genuine cognizable interest that is harmed by a principle permitting the practice of lifestyle medicine. The interest is one we all have, I think. It's an interest in not being made to feel badly about ourselves and our choices. In medicine, there is no shortage of patients who engage in illicit drug use or participate in risky sexual behaviors, who smoke or consume vast quantities of alcohol, who lead sedentary lifestyles, sometimes all at once. And some of these patients, I assume, do not want to hear about it. This is especially true if they believe, rightly or wrongly, that their consequent health problems can be solved with a pill, an injection, a surgery, or some other technical intervention. As Danny Peer, then the vice president of the American College for Preventative Medicine, opined just 4 years ago, quote, prescribing lifestyle is a really difficult thing to do. Lifestyle is low-tech and very intensive. It is very difficult to do both for the physician and the patients, close quote. But what really is the nature of this interest against being made to feel badly about ourselves and our choices? And is it weightier than our interest in being fully and honestly informed about our physical health? It seems to me that what Dr. Obuobi elides from her op-ed is the possibility that she is subtly harming her patients by depriving them of information and recommendations that are relevant to their health, when what she should be doing instead is finding ways to communicate that information humanely but honestly and in keeping with the best evidence. In other words, none of us has a legitimate interest in being kept ignorant or having real problems ignored to spare our feelings. What we do have is a legitimate interest in being treated with respect. A patient who would be better off quitting smoking or regulating their dietary choices should not have those things communicated to them in a cruel or demeaning way. In other words, the legitimate practice of lifestyle medicine appears to depend in large measure on empathy and thoughtful communication from clinicians. But a patient who asks that medical providers disregard evidence in favor of affirming social, cultural, or emotional prejudices is asking to be treated with something other than medicine. On balance, then, a principle forbidding the practice of lifestyle medicine appears to impose greater costs on important interests than a principle permitting the practice of lifestyle medicine. In other words, lifestyle medicine is a morally permissible pursuit. In demonstrating this modest thesis, I hope to have shown some of the ways in which concerns of extant critics may be alleviated or countered. I also hope to have shown how simple, ubiquitous ideas like evidence-based practice and good bedside manner are actually central to moral considerations in medical practice. I would like to conclude with two brief observations regarding the limitations of my argument, one theoretical and one practical. The theoretical point is that my modest thesis has a stronger formulation. If you accept my argument that lifestyle medicine is morally permissible, you might wonder whether it is in fact morally obligatory. That is, whether it would be morally impermissible for medical providers to exclude lifestyle medicine from their repertoires. I think this is an interesting question, well worth your careful consideration, but ultimately beyond the time I have today. The practical limitation is that the realities of insurance coverage, business competition, market demands, and similar considerations may substantially complicate the practice of lifestyle medicine, quite regardless of its moral worth or even its effectiveness in improving patient health. Among the most basic principles of ethical reasoning is this: ought implies can. Morality never demands that you do the impossible. So, what's possible? Faced with that question, I can only plead that I remain less useful than a large pizza, even one with a cauliflower crust and vegan toppings. So here I must defer to someone with relevant practical expertise. And well, that's you. Your expertise is needed, not only to advise patients on matters of personal lifestyle practice, but to advise politicians on matters of public policy. Your engagement with your communities beyond your practice will have an impact on the health of the people who matter most. I look forward to seeing what you can accomplish. Thank you.